Okay, great. So we've reached the last session. I'm gonna make sure we are done, certainly no later than 12:15, but maybe even a few minutes before. First of all, I just want to say thanks to everyone. A particular thanks to Emily, who has organized this. Just thank you, thank you, thank you, thank you, thank you. I found this just really, really valuable. And I hope that in this last session, what we can do is talk about what comes next. And I think there are a variety of ways to approach this, but my inclination is, I think we've said a lot even in the last session about things that can come next. And I love to sort of turn it out to all of you and say, what are some of the things that you've heard that may come next? And, where's your thinking on some of those things? And, we'll add some too, obviously. But I want to both hear the things we've spoken about and that people think are good ideas and we should think next, and the things we haven't talked about that we should be. So, Andrew, Elaine, Emily, do you guys want to add?
Maybe I would just add, so I think we've hit on some of the evaluation pieces and there's a lot more to talk about and we should continue to now. And I'll jot some of that down. But also wanting to put out there the ways in which we can be helpful to each other and us through the Comprehensive Care Institute and building tools to support. There's a lot of experience that was shared in the room yesterday and today, and we can be thinking, I think, a lot more about how to codify some of that in ways that are useful to other sites that are identifying barriers and identifying ways that other sites maybe have experience that another, it doesn't have to come from just our experience at UChicago, and kind of creating a centralized place for those tools.
And Emily, you're gonna take notes for us?
Yeah.
Okay, so actually along the line of that, one thing we didn't talk about in the meeting, much really is practice management skills and revenue generation. And one of the things that we've been working on is beginning to build these advanced primary care management fees that were just approved in January. My estimate is this is a lot of money. And it's enough money that it could flip the economics of building primary care capacity from being something that needs to be subsidized to something that could actually, make sense from a business perspective. Now, that depends a little bit on how much you support the primary care providers. And if this becomes a way to just basically put primary care doctors in jobs that are unsupported, that won't work. But I think that's one thing we hadn't talked about. That's an area where we could support each other. Anyway, maybe the least important. So let's throw it open. What did people hear? And I'll just see maybe with a first thing. We definitely talked a fair bit about evaluation in the last session. So and we have this slide up here to talk a little bit about some of the different types of studies that could be done that look at implementation and effectiveness together. And we talked about these ideas of studying Rounder, like has begun at Wisconsin, studying CCP on top of Rounder. What do people think about those ideas?
I think my only thought is like all of the institutions are in different phases of maturity. For example, like you guys are probably the most experienced, Vanderbilt and all of that. And then there are that are not as, mature yet. And I think there's something to be said that it takes some time to kind of build the group that you're ready to evaluate it. And I think that was the concern we had with Vanderbilt before was, are we evaluating at the right time already for that group? Because we don't want to evaluate it too early. That what if it's a bad result, right? And then you're gonna lose that momentum. So I think, for example, like with Giovanni, like you have implementing something and studying it, you have to kind of be intentional about it. Because at least when I was thinking about it, people love good outcomes. right? So there, you're gonna lose a lot of momentum if you study and it doesn't look good. I don't know. That's what my thought is.
So can I just comment on something? These hybrid type 1 and hybrid type 2 designs, the primary outcome is the clinical intervention effective? Okay? And when I sort of envisioned where our conversation would be, I was sort of thinking about this. But I'll point out that, you know, implementing Rounder as an implementation strategy for CCP could put us over here.
That's a good idea.
And we've already shown in some sense
Right.
it can be done, but you know, we've shown it in one place. Right? So could we, and yet we're set up to do others. At what you're doing in Wisconsin, you guys are sort of this, maybe?
We are truly at the, just even before that, we're really a feasibility. Right now, we are trying to understand, can we reduce fragmentation? Can we get patients, so take for instance, yesterday, if you remember Russia's model, how many patients did they get back onto the inpatient team? 30%. I think people overestimate in a complex system how hard it is just to get patients back to the team of interest. I know it's been done at Vanderbilt, but it didn't happen overnight. It took 3 years. To your point, I think you're right. You don't want to study effectiveness until you know you can actually get patients onto your team, because otherwise you have no fidelity. The patient, like, of course you can't improve outcomes if the patients don't come to you. So I think we're still at the stage, myself, at least in the Rounder primary hospital provider model, can I actually get a patient who's readmitted back onto my team? That, you know, it's actually, like I said, because the triage part is very complicated.
So one thing I've always been very impressed by clinical trialists about is their ability to write papers about research they haven't done yet.
Yeah.
Right? Like I published my protocol. And I wonder whether, you know, one of the papers we need to collectively write is an implementation science paper that just talks about all the steps in this process that it can get messed up from, you know, the very beginning to the end, and sort of, you know, where all our work fits within the whole. And, you know, where the gaps are and what the needs are. And I think that would be useful for us, as evidenced by your answer to my
Yeah.
question.
And the way to tie it into a implementation science framework, so it's not just a descriptive kind of study, is this idea of fit to context, which relates
Yeah.
to you build from strength. So we can use that as the scientific framework of you had evidence and people, you have a natural experiment happening. Everyone is trying to fit it to context and that, and just understanding that, which then leads to what you're saying is just that descriptive piece. But we can do it in a way that says, what's the generalizable learning and what's the local learning? And that I think would add a lot of value from an implementation strategy describing.
I also want to just add one more thing. We are going to be putting in our CTSA renewal in the next year. And we're going to be thinking about, you know, how implementation science is front and center. There are some resources in that.
Right.
You know, maybe that is a way for us to begin to seed some of this, complement the other CTSAs. We have amazingly strong CTSAs represented in this. And that might help us seed some of this work.
Right, so maybe it's not a traditional RCT, it's a translational science challenge. You have an innovator site, they demonstrate a model X. Other sites are interested, they have to fit it to context. That's the translational diffusion thing, and maybe that's how we're trying to, you mentioned toolkits, right? So if I was a sales organization at pharma, I'd anticipate these are going to be the frequently asked questions. I have tools in my toolbox that are ready to go, and I go to the next person I'm trying to sell it to. That's what we could extract, like what is that tools that you need? What's the protocols that would make it useful for the next group? That would be how do we accelerate the translation or diffusion of innovation model A to other sites? And that could be a way of framing the work, that kind of builds off of the collective already energy and implementation going on. Just some thoughts. And I don't know if that kind of study would fit a UO or whatever the mechanism is for the innovation across CTSAs. But,
I think it has potential too.
Yeah.
And that's even prior to the renewal,
right.
right? So,
And that might help to, you're kind of that herding cats problem where everybody has such a different context that they're working out of, but something like that might continue to remind everyone, here is the goal, so that it doesn't get so far astray that you're actually not, you're fragmenting again.
Yeah. I do think we need to be careful to be a bit agnostic about the goal in the following sense, which is that although, at least for me, this began with CCP, it's possible that, say, Rounder is so good that the incremental benefit between CCP and Rounder is not that great. Which would be fine with me, right?
But fragmentation is the thing we're all trying to
That-
avoid,
that
and
is
that's
the
what I'm saying, maybe
ultimate
that.
target.
needs to be-
That is what this is in the end about. And I personally suspect that inpatient, outpatient continuity and interpersonal relationships in that space have unique value. But, one of the first principles of policy analysis is fully define the set of choices, right? And I just want to make sure that, we start with that first principle, which is we need to be clear about the potential choices we face. And it is more clear than ever that we have an intermediate choice that is of meaning. And, we still are living in the world where we're not even at that intermediate choice. And, so there's there are ways to improve that are multiple.
Maybe a first step is very clearly defining the choice sets of what's already happening in a way that, and sort of again, building off of the building from strength, right? So it was a fit to context choice, and maybe we just have to take what we heard and put it in a very clear description. So here's the discrete choices that are going on right now, beyond just what were slides presented.
Yeah.
You can show like the flavors that are happening. And yeah.
So for evaluation, I think we kind of are in agreement, we need sort of a framework sort of paper. And I think we see opportunities maybe in several of these, for different studies, whether it's about implementation of Rounder or implementation of CCP on top of Rounder, whether it's about studying the implementation itself or studying the outcomes of it. And I think, we probably are going to need calls and groups to kind of talk that through in deeper detail in the coming months. What else did people hear as next steps? What questions do they have?
How is the qualitative, if we're getting qualitative data on patient stories, who is that impacting and who values that, and how are you distributing that? Because I think that could be, is there like a YouTube video of a patient story? Is there, those things could happen or something, yeah.
Yeah, so I mean, there are methods like photo voice, et cetera, that could be scaled so that maybe there's one way of, rather than every site having to reinvent the wheel and figure out how to get it done, could be a collective.
So we've already created 2 videos. Wald is the star of one, talking about his experience as a CCP patient.
Right.
And we have a second one as well. They're both great. They're both different. We could certainly share those with other places, and we could create a library of these. And we've used it in some of our recruitment. It's been valuable. There have been different ways to produce those, but a lot of our universities have, media offices, sometimes that will do things for free, sometimes they charge. We also have had students who are very interested in producing things like that. So that is one strategy. I also think that what we've done within our, monthly program meetings where we just have individual quotes from patients has been amazing. And sometimes those little snippets, they're so much easier to produce.
Yeah.
And, but Joyce, I mean, you've done a lot of qualitative research around CCP. I mean, I suspect there are others at other sites who would be interested. Maybe we should have like a qualitative research working group.
That would be great.
I think related to that is how can we leverage qualitative data to sort of drive support before we get quantitative outcomes? So like when I was talking about Rounder, I shared two stories that would certainly resonate with hospital administrators that you would see about patients whose, length of stay and readmission rates were able to improve. And that's not quantitative, but I think we can leverage that to continue to build support as we go.
Like, can we leverage like traditional media or like social media to kind of, because like what Ed was saying, I don't think people know that this is an issue, because unless you've been hospitalized so many times, you never think that, oh, I didn't realize that the same visit, it's a different physician. So people don't know, right? And sometimes and I'm assuming with traditional media, there's ways to kind of get that word out that, hey, if you're gonna be hospitalized, and I take care of a lot of dementia patients, they were so frustrated about this situation. So getting that word out that there is another way.
So this is actually a place where the CTSA might be helpful. So every one of our CTSAs has communication groups. And Sarah Saratella, who does it for the ITM here at U of C, has been very connected to that group nationally. And Sarah is like super creative. Like that is what she is all about. And she's very well connected nationally. And I do wonder whether we could pull together, Wisconsin, Vanderbilt, ITM, communication group around the CTSAs to get this present. And remember, that then could easily get brought and it would get seen by 60, 70 CTSAs all around the country. And CTSA, like every NIH program, is in a fight for its life. They need to make the public case that what they're doing matters. So we've all done this. This is direct patient impact.
So as you build all right, so this is what you might call market shaping. You're making it, think back to when Merck first had to sell its Mevacor. People didn't really understand what cholesterol, why should I care about cholesterol to the degree we know now, right? So a lot of the scientific dissemination and medical affairs work was to raise awareness, right? So you're kind of doing that same analogy. So thinking about, so how do you want to label the collective? Is the label what you have in the conference, which is complex care coordination or continuity, of which there's the CCP, of which every institution can still be proud of the program they're doing in this family, as opposed to saying it's a CCP only and you have variants. So thinking about that, so every site can be proud about contributing to the collective. Is that, you see what I'm saying?
Yeah.
Otherwise, we're gonna end
I
up
think Donald
fragmenting.
Trump understands his doctor. This is your doctor.
Right.
Like you should have someone who knows you. And they hate him personality.
Right, so that you're going with the common story so that I'll just give my example. If I went to Loyola University Chicago and I wanted to talk about it, those marketing people are gonna want to say, look how great Loyola University Chicago is with the program I've developed. I'm sure every institution is gonna want to do that. They're not gonna say, look at us, we are doing something that U Chicago did, right? That's just natural. So if you can come up with like the overarching generic term that then allows everyone to say, we're part of this national movement, this is a big problem. We're all this coalition or whatever, a collective, and we're trying to understand what is the best, most efficient way to fit and solve this problem, as opposed to just saying, I'm gonna take my brand and
Yeah, no,
diffuse.
yeah.
And so thinking that through, I think would be helpful. Is that? Otherwise, you might end up competing with one another.
I
It's like,
think
yeah.
that's okay. I think that's something we can handle. What else? I mean, I'll keep throwing things out. I think we should talk about meeting again and what that should look like. And let me just share my thought, which is that it's gonna take a while to get a next grant. I also think that we have an opportunity in the spring next year with SGIM and SHM meetings as a chance to convene at very low cost for many, many of us in the context of something we're already doing. So I'm thinking that we should target the fall after that. So the fall of whatever, what is it, 2026?
It'll be the spring. Those meetings are always in the spring.
It will not be, yeah, so it would be in the fall for, no, so we would, in the fall, we could meet together.
Yeah.
At meetings we're already doing.
In planning. for-
I'm sorry, in the spring.
Yeah.
In the
yeah.
spring would be, and then in the fall, by then hopefully we've got money in place and can plan for something. As a timeline. And I think you guys will remember, we got a 1-year ARC grant and then we got another 1-year ARC grant. And I think now we're probably ready to go for, I think it's a 3-year cycle. And then we could get 3 years, we don't have to keep writing them. But I think we're now at that point and, paper out, we'll have stuff to show. I think that'll be good. What else? What have we not talked about?
Building the grassroots in the high schools and colleges.
The training.
Seemed like training. Learners seemed like a really good thing to somehow impact.
I agree, and I'll share, like, we have some connections to the American Board of Family Medicine, who expressed a lot of interest in this too. So I do think we should have some sort of training group, which will have its own agendas. Obviously, sort of the whole pipeline feels really important. Obviously some of these folks may become physicians, but a lot of them may not, and I don't think we should limit ourselves to that. And so I think that's really worth doing. There's also a synergy, which we talked about a little in the last session, between research infrastructure and training. And I think we need like a research infrastructure group and then some intersection in thinking between those two things. So, we're gonna need help to do this work. And I'll just share, we would have never, ever finished the PCORI C4P study were it not for AmeriCorps. I could never have done it without that money. Because, we got other help, which was great, but like that actually is put it together. I don't know, Emily, you may remember the numbers better than me, $2 million ultimately through AmeriCorps. It's a lot. And once you learn how to do it, like we could do that together. So I think, we need like a research infrastructure working group, which should tie to training. I'll just also share here at the U of C, like there's a lot of retrenchment going on in training opportunities for students right now. And the university is trying to figure out how to shepherd the limited resources that it's going to have. And I think a lot of our universities are going to be in that situation, but I also think there's a lot of untapped potential. I can only imagine like at Wisconsin, like how many undergrads you guys have. Like
We're the 13th biggest school or something like that in terms of student enrollment. So
yeah. And a lot of work study students,
Yeah.
and that's an amazing resource.
Yeah.
And so we're gonna need capabilities that go beyond whatever the grants give us. And I think we should start building them now. And you can use them for all sorts of purposes in the interim, but know what we're building towards. Yeah.
Yeah, I agree with a lot of this. The one thing that I would even take it forward is, who are we? What is this? Very philosophical, but is this an opportunity that are we entities within SHM, SGIM? Are we our own society? If we build a society or coalition, do we create board of directors? What's the mission statement? And I like SHM and SGM, but sometimes it feels repetitive that people are just using those as opportunities to get their work out there, but there's not necessarily a takeaway. Do we actually build the infrastructure of like deliverables of these working groups?
Yeah.
Yeah, I mean,
So
it's more operationalizing this.
yeah, and you know, we did create this not-for-profit, the
Yeah,
Comprehensive Care Institute, which, you know, at this point, it's Emily and Andrew and I are the people who signed the tax forms.
Yeah.
You know, and I think really thinking intelligently about how we want to use that to do the things we do is absolutely the right next step. And we should be building out a board. We should be building out structures that do that so that, you know, the answer to that question is evident.
Yeah.
Right? And we haven't done a lot of that. We've been focused on getting like the conference done, trying to figure out the next steps for the work. But I think building out that organizational structure, and I guess I'll also just add that when we do that, as we do that, and as we think about interacting with SGIM and SHM, we can come in as individuals, but we could also come with an organizational presence. So I was the president, I don't know, 15 or 20 years ago of the Society for Medical Decision Making. And the Society for Medical Decision Making would, and maybe still does, co-sponsor events at SGIM. And so I think that's something that we should do. And I actually think that will help us with both SGIM and SHM. So one thing we should do is, as we think about bringing our work there, you know, particularly things that involve more than one of us, to make sure we're kind of bringing it with some co-marketing. And then Joyce, you may know this better than I don't even know who's leading SGIM right now, but we should think about whether we know the leaders and whether we can connect to them. And yeah.
Yeah, and I was gonna say, I'm part of a few organizations which definitely have some rules. So for instance, the US Do Prescribing Network, we actually have our meetings every year, every other year. It rotates now between SGIM and AGS. So it's the day beforehand, so it's very convenient because we only have to fly once and add an extra day. And there's obviously a lot of crosstalk. The American Delirium Society is another organization which strikes me. They're both born out of the NIH, but I even think of, you know, from I know that Home Run, which is a hospitalist medicine kind of a research organization, you know, they're kind of at that stage of trying to find like, what are we setting up these boards, organizations, formalize these executive committees, but I think latching on to SGIM, SHM is be very smart and strategic. But I would just, you know, figure out what else is latched onto them as well, so there's not too much competition.
Yeah, and I'll also just say, like, I think there are opportunities with Home Run.
Yeah.
As another example. And I think for the most part, kind of more connections is better at this point.
Yeah. Because I mean, to me, a next step is just like, you know, gosh, you know, all the people in the room are past the pre-contemplative phase, you know, really that, you know, if you're thinking about that study, it's we defines 10 hospitals that want to do this. We do a pragmatic, RCT of mentored implementation, and we give them some tools and figure out how to get it done. And so I don't know who those 10 hospitals are. And so, but
I also do just want to say one more thing about the CTSA, which is that it is unbelievably well known and it has resources, and there's no real competition. You know, like you could imagine hospitalists are a little threatened by us, and that general internists are a little threatened by us, but the CTSAs really aren't. Like, we just bring things to them.
Yeah.
And they're looking for hits.
Right.
So, you know, I think the more partners we have, the better we're going to do with each of our partners, probably.
So there are have been supplement awards, right? So I'll just take the one I was involved in, which was this innovation core training. There were 9 original sites that got pilot funding of like $25,000. And we all started implementing it. And then the group said we want to diffuse it to 20 more sites. They wrote that diffusion grant and then studied it and evaluated it, right? So you could be thinking of this, you know, the institute work that's going on here is that sort of self-seeding. And then across the CTSA, that it was a dissemination supplement award that UAB got for that.
Yeah, I forgot to check the amount on these.
May not be enough money.
They're these CCIA awards, CTSA Collaborative Innovation Awards. They're at least in the range of several $100,000.
Yeah.
You know, which doesn't go that far if you divide it up on too many sites, but like we're not yet way too many sites. So that may be one possibility. But you know, we'll want to look at that and other things. So we have about 10 minutes left. What else?
I have a question which is fairly primitive. How many sites, do we have an idea? I have no idea. How many sites around the country are actually using CCP? I mean, what are we talking about in a population of healthcare or patients?
So I'll give you two answers.
10?
Yeah, I don't even think it's that many. I think it's under half a dozen and most of them are in this room. But what I will tell you is that if you ask how many doctors in the US will see patients in and out of the hospital, the answer is still in the hundreds of thousands. And that is because they are doing it as individual practitioners. So we have a paper that's almost done using Blue Cross Blue Shield data, showing this for Illinois. And I think there are many thousand just in Illinois who are still doing it. They're mostly older doctors. Many of them are in rural environments. So they're out there. And you know, what the paper shows is that it looks like there's some evidence their patients do a little better.
I think the question is, how many hospitals exist where fragmentation due to economies of scale occur? Right?
Or that could be solved by this problem.
Right. So
I
that,
think the answer is as many as there are hospitals.
well, I guess my point is how many of the physicians that do both are like small community hospitals, or they don't have the issue of 10 hospitalist teams where the idea of discontinuity occurs, or they follow the patients in and
My
out of the hospital.
understanding is that the penetration of hospitalists in hospitals in the US at this point is, I don't know, at greater than 70%.
Yeah, so we've got.
Well, I think that's the answer to the question.
Yeah, so the answer is, there are many, many places that could do this.
Yeah. But the amount that have done it are.
That's where I was describing is that there is, in my mind, I still feel like there's value just to
Yes.
doing a survey of hospitals, say, how many teams do you have? Like, and just show, like, it's 1%. That actually have a team-based model of care. It's shockingly low, and when it's obvious to us, it's not obvious to everybody out there.
Yeah. One sort of, I think that idea of a survey is very interesting. One possibility might be to complement it with the data that we have. So we have Blue Cross Blue
Yeah, and
Shield
if there's another
national
way to.
claims data.
Yeah,
And we could sort of know what I think we can identify the actual hospitals
Yeah.
that these doctors are at, and then reverse engineer it and go and survey them
yeah.
and say, we see in your hospital that, you know, you're doing this, you have hospitalists, you know, a bunch of other stuff.
I mean, an implementation question, for instance, is I would think a primary hospital provider model, rounder model, form of care, like you need to have a certain number of teams before it actually makes sense to have a cohorted team, so you have to be big enough, but not so big. And so I don't know what that number is. I certainly know when I got to Wisconsin, we're like, we can probably form 3 of these teams, let alone one of them, but. Yeah, so it probably doesn't work for all hospitals, but is it 4 teams? Is it 3 teams? Is it 5? I don't know. But it's an implementation question.
And I'm curious, like with the consolidation of health systems right now, this defragmentation is the end effect, of it. And it's not, no one's trying, like we see all consolidations and closure of rural hospitals, health systems buying all of these clinics. This is like the natural effect that no one's tracking, but it's happening in real time.
Of Kaiser Family Foundation, who tracks a lot of these kind of policy, kind of macro level might be a good partner. In that, them writing policy statements or things like that as well.
Yeah, I do think this idea of CCI creating like a board of some type, it needs like an internal leadership structure of those of us who are most involved in this. But we have a set of national friends. Like Bob Phillips from the American Association of Family Practice has been very supportive. I'm sure he would join. Trent Haywood is someone who used to be a senior executive at HCSC. And he's been very supportive over the years. Like, I think we could assemble a bunch of people who would help us, be able to go to places like the Kaiser Family Foundation and say, we've got, Shri, I'm mispronounced, Shadagru was here last year from CBS. Would be another person who's a national figure. I think, and we have a.
Francis from Cigna.
Yes, exactly.
Yeah.
So, okay, we have just a few more minutes. What else do we need to do? If a year from now, we haven't done the following thing.
I mean, I'll just throw out, we talked about, Sarah is somebody who we're trying to, I just think there's so many questions out there. That thinking about the research infrastructure and junior investigators and really thinking about them and how do we foster. And I think it's tough to be a junior investigator right now. This is a scary time, but I'm bullish. This is a time to invest. This is a time to, because we're going to be ready to go. Things change. So just thinking about that research infrastructure, but especially our junior investigators and how do we support them and build a network to make sure they're going to be who make this, like, we're still at the infancy. So we want to make sure to grow that body.
Yeah, and I'll just say, with a young section and a section where people are getting promoted, when it's time to get promoted, people need letters. And, it can't be a letter from your mom.
Yeah.
They've got to be armed, as great as it is to have the support of your mom. It is, the connections that people make in small groups like this are close enough to be able to write meaningfully about what people do and arm's length enough to be able to count.
Yeah.
And so that's one of the ways we support junior investigators, but I think we clearly need like a research group.
Yeah.
That's talking about how are we supporting multiple young investigators? How are we building research infrastructure? And, I think that, sort of seeding these groups and making sure that we can sustain them with, staffing we can handle and all that sort of stuff. Like that feels like it's really high value.
I would say something where American Delirium Society has done a very good job of really building and growing junior investigator. They have a boot camp, it's like, we need to actually teach them the skills and how you do this kind of research and how do you think outside the box and do quality. And so, it's a good group to look to.
Right. Okay, any other last things? Okay, let me just say thank you all so much. I feel like I learned a ton. I think we've made meaningful progress. I think about 18 months ago to now, and it feels like palpably upwards. And I'm super excited to imagine what 18 months from now is going to look like. And we have a lot of work to do between now and then. But I feel like we have a bunch of very actionable things. And again, thanks to everybody, Emily, thanks to everybody, Elaine,
Great.